So at this point, I'll throw the floor open to questions.
Hi. I would like to ask, okay, just need a Herb Karpatkin, a few things,
Herb.
please. It's about heat, and I'd like to know how or why heat affects. Also, is Bikram yoga and stone massage, you could say something about those two things. And lastly, foot drop, is it always because your calf is weak, or are there other reasons?
Okay, well, there's three things there. Bikram is the hot yoga. Yeah, stay the heck away. All right? Can I be any clearer about that? Okay. Really, in addition to it being clearly contraindicated for most people with MS, the artificially induced laxity that the heat causes has actually led to musculoskeletal injuries. So that would be one thing. The foot drop is, to get to the second part of your question, foot drop is multifactorial in nature. In my experience, it's a combination of several factors, usually having to do with tightness of the calf muscles, which may or may not be complicated by the presence of spasticity. And if there is spasticity and it's not treated, you must speak with your physician about that, because there are very excellent pharmacologic treatments for spasticity, but stretching has to be part of that. In addition to the tightness, there is almost always weakness in the opposing muscle group, so stretching by itself is not enough. And stretching and strengthening by itself is not enough. You have to relearn how to use that joint, that muscle, that segment, because as a result of the weakness and the tightness and the spasticity, your body has unlearned how to use it. So there's many parts that goes into it. There's certainly medical management, but in the physical management, there's stretching, there's strengthening, and there's retraining. And your final question was, how does I don't believe hot stone massage is going to. I think it's too local for it to actually cause any worsening of symptoms, unless the stones are kind of enormous, which is contraindicated for other reasons.
So hot boulder therapy is contraindicated.
The science behind why heat interferes with physical performance, on a basic level, I could say that demyelinated nerves conduct impulses more slowly when heated. At a more in-depth scientific answer, I may defer to Dr. Miller on this one.
So, the basic fundamental issue is that things that raise your internal body temperature are likely to potentially make your symptoms worse. They don't always make symptoms worse. Some people can go with impunity into saunas and jacuzzis, but you'd better have somebody with you when you first try it. And if you find that it's problematic, it's something to avoid. There's a question back here.
Hi. Earlier, I'm sorry I can't remember what the doctor's name was, but they spoke about upon your first diagnosis of having MS, it's like suspected MS, and it can move on to confirmed MS. However, I also heard a separate doctor speak about if you get treatment early on, there's a possibility of it not progressing to the confirmed MS. So I was just wondering why, because later on I heard that on somebody's first exacerbation, there's a possibility of it, or it wouldn't be treated immediately. And I was just listening to all of the different points, and I was just wondering why, at the first onset of MS, why would it not be treated if there's a possibility of preventing it from progressing on?
Okay.
So you heard it all correctly. And so paradoxically, we can treat MS before we can diagnose it. And we have studies that show this. So when you have your first attack of MS, even though it is the first attack, you may not meet our diagnostic criteria yet to say, yes, this is MS. But If at the time of that first attack you have certain other things going on, including some changes on your MRI scan, we have very good clinical trial data to say that if we treat you at that point, then the chance of you going on and having the next attack, which would define you as having MS, becomes significantly less. And so we do that. And we are in this paradoxical situation of saying, well, you don't have MS yet, and by treating you, we're going to keep you from getting it, or at least lessen the chances of you getting it.
So wouldn't it be more prudent, to, if you have a suspicion of it on that first exacerbation, to just treat everyone, just in case?
Well, so again, if you have the first attack of a typical of MS, and you have some MRI changes that indicate that you're at risk for having more attacks, then yes, our studies say that would be a good idea. And that's a discussion that you would have with your physician.
Who's got the mic?
Oh, my question was, me listening to you, the interferons and the Copaxone seems right here, over here. Right here.
All right, go
See
ahead.
me?
We can
Right
hear
here,
you.
Right here. Okay. It seems like the what is it called? The Copaxone and the beta interferons. You talked about if they're different. If they both treat the MS, how is it different? Like, the doctor said, oh, you could take the beta interferons and you'll be fine. But then the doctor said, well, we're going to prescribe Copaxone. So I wanted to know, what was the difference?
So the point that I wanted to emphasize this morning about Copaxone versus the interferons is that they appear to be equally effective. A decision about which of those agents you ought to take, or an individual person ought to take, really depends on exploring with your doctor what other issues might be particularly important to you. So, for example, the side effect profile of the interferons tends often to be a little bit more interfering with one's life, at least temporarily, than does Copaxone. On the other hand, Copaxone is a daily injection, and interferons are taken less than every day, depending on which preparation you take. It might be every other day, might be 3 times a week, might even be once a week. There are many individuals who are willing to put up with the somewhat worse side effects in order to take fewer injections. Other people might not care that they have to take a daily injection and would rather avoid the side effects. Some women might be about to contemplate pregnancy, and although this is a somewhat controversial subject, in my view, a woman might consider being on Copaxone while she's trying to become pregnant, but not on the interferon. So there are a lot of other issues that play into that decision, but it's not a matter of one of those drugs being more effective than another.
Okay. Hi, I have a two-pronged question. My question is, I'm wondering, do you think it's best to see a physical therapist as opposed to a trainer in terms of exercise? Because the trainer is licensed, but not in terms of MS, you know?
Well, we'll ask Herb to answer that, given that he probably has a conflict of interest despite that.
Actually, I would rather you see a trainer who is highly skilled in MS than a physical therapist who isn't. And very often, I will often refer to a trainer if a patient, either because of insurance issues or distance, cannot come see me, and I will communicate with the trainer. I think regardless of who you see, you have to make sure that this is someone who truly understands MS. And physical therapists do go through a much more aggressive training program than a trainer does. It's now a doctoral program. It's 3 years with a research component, with extensive internships involved, and the training is quite extensive. But it's a generalist training. The amount of training that they get specifically in MS is relatively small. So to answer your question, you should find somebody who, A, has training in MS, and B, who really motivates you and gets you to do the work.
I think that's a generic comment that's very important. MS is a very complex disease. It involves many aspects of an individual's life and of the lives of the people engaged with that individual. So most important, no matter what the issue that's being addressed, is it should be addressed by people who understand MS and can relate it to a particular individual. So the physician that you see should be knowledgeable about MS. If I refer a person to a social worker or a psychologist or a psychiatrist, I want that to be with a person who understands MS, not just an ordinary therapist who doesn't have any understanding of that disease, and the same thing goes with physical medicine.
Thank you. In the first talk, they mentioned Sjogren syndrome, along with Lyme disease and a few other diseases. Well, do you know what was meant by that? What they look for with MS versus Sjogren's? Because I've got both. And in the beginning, when I was first diagnosed, they were trying to find out whether I had central nervous system Sjogren's versus MS. So what do doctors look for now to differentiate between the two?
So there could be an overlap with a number of illnesses that can affect the central nervous system, and that's what the purpose of that slide was, to show that other diseases that are part of the diagnostic process of picking MS, excluding those, or vice versa. There's no specific way of doing that. It's rather looking at all of the evidence based on the examination, the history, and the laboratory studies.
I think one of the points that Dr. Fabian wanted to make about that this morning, which perhaps wasn't completely clear, is that many of the diseases in that list, such as Sjogren's, for example, or lupus, for example, are other autoimmune disorders. And there are blood markers for those disorders. They have characteristic antibodies, for example, that are typical of those diseases. The problem is that when a person has what looks like typical MS, a lot of doctors will send off a battery of blood tests looking for those antibodies. In MS, there are a lot of other autoimmune antibodies that come back somewhat elevated and tighter. It's not the presence of those antibodies alone that define these other diseases. So you don't have Sjogren's syndrome just because you have antibodies. You don't have lupus just because you have elevated anti-nuclear antibodies. So lots of people with MS will have elevated Sjogren's type antibodies or lupus type antibodies. And if they don't have other evidences of those diseases, they don't have those diseases. They have MS with a propensity to develop higher levels of antibodies.
Yes, Dr. Miller. Dr. Miller, I want to ask Dr. Lublin about neuroprotectors. Neuroprotectors, you said, are kind of risky for use. What are the kinds of things that could happen if you're on a neuroprotector?
Well, right now we have no neuroprotective strategies that actually work. So they're being tested. There's been a number of molecules in the past that have failed in clinical trials, in part because they didn't neuroprotect, and in part because they were too toxic to give. But the list of potential toxicities is really quite long, and what we need to do is find something that works right now, and that's what we're trying to do, but it's still the very early stages of that sort of work.
So first of all, I think the important thing to emphasize there is what Dr. Krieger talked about this morning. That is a single report of something happening is just a single report which has many potential explanations. These are anecdotes. I can't discuss that particular case in detail because I don't know anything about it. We know people that spontaneously remit, for example, spontaneously get better, even from what seem to be dramatic levels of impairment. Chemotherapy, by which we generally mean drugs that profoundly suppress the immune system, have been used in MS and continue to be used. They're used much less now because we have much more specific and safer drugs. for MS. But these drugs which suppress the immune system are being used in general the same way we use other drugs, with the expectation that we're going to decrease the likelihood that new disease is going to happen. They don't cause repair of the nervous system. So I don't, I'm very happy for the young dancer, but I don't have an explanation for why that occurred. Go ahead. We want her to have a microphone to say that.
Again, I want to say thank you. I found this to be incredibly informative. I came today because a friend of mine is newly diagnosed, and I think I took away as much from being here today as did she. And also, Dr. Lublin, I would love a copy of the picture of MS with the blood-brain barrier and all the hundreds of colors, so that when somebody says, "Oh, can you explain MS to me?" I can say, "Yeah, here's what an MS profile looks like."
I'll give you the name of the person I stole that one from.
And also, just to say to an old friend, Dr. Herb Karpatkin, I've been his patient for many years. When I met him, I couldn't even turn my head. I had such difficulty. I needed vestibular therapy, which is just balance therapy, before I could even get into the walking part of it. Unfortunately, right now my insurance is holding off, but I'm going to start up hopefully with him next year. Anybody who has the opportunity to see Dr. Herb Karpatkin should do it, because he changed my life. And also to Millie, I love that a woman who was a nun and became a lounge singer, now married a nice man, a Jewish man, and that beautiful song you sang, thank you. To all of you, this was a spectacular day. I'm very grateful. Thank you very much.
Thank you.
Yes, I've been to a number of physical therapy offices and seen a number of physical therapists. And I always ask for someone who specializes in MS. I've never been referred to one. So how does one find these kinds of physical therapists?
I'm sorry, could you?
How does one find a physical therapist who has special expertise in MS?
Unfortunately, it's not easy. There aren't that many of them. There's two places you could look at. One is you go to the American Physical Therapy Association website, and there's a service on there called Find a PT, and they'll list a bunch of PTs by location. You put in your zip code, and it will localize a PT for you, and you could see if that PT does have specific expertise in MS. What you should look for, though, the one way to be sure is to see if a physical therapist has these letters after their name, CMSC. It stands for Certified Multiple Sclerosis Specialist, and it's a specialist designation given by the Consortium of Multiple Sclerosis Centers. You can find out which therapist specifically has those by going to the website of the MS Consortium, which is mscare.org. And within there, you'll see a tab for the, too many letters here, IOMSRT, the International Organization of Multiple Sclerosis Rehab Therapists, and that will provide you with a list of all therapists who do have that designation. Sadly, there just simply aren't that many. At my office, there's a couple of them, and we try to have a lot of training for therapists to train as many people in MS as possible. I try to talk to as many therapists as I can to try to make them aware. But there is unfortunately not too many, and a lot of therapists think, well, I can treat a stroke and I can treat a bad back, I can treat MS. And that just ain't the case.
Dr. Miller? I'm over here. First I want to say to Dr. Karpatkin, thank you for assuring me that rigorous exercise is okay, because I'm newly diagnosed and it's concerned me. I hadn't really talked to anybody about it, and I'm not a Bikram yoga person, but I do have an exercise regimen that I started, and it's just a big relief to hear that, so thanks. Dr. Lublin, very close to the end of what you were talking about, you said something which was intriguing, and that was something to the effect of, we have treatments that are helpful, but they may inhibit repair. You said something like that, and I'm curious as to what you meant, if you could expand on that a little bit.
No, towards the end, what I said was that therapies that, like immunomodulation, are very good for immunomodulation, but they theoretically can inhibit some of the molecules that are involved with repair. So that's not something we've seen in the clinic, it's something we've seen in animal studies. And so as we move forward and start thinking about repair, we're going to have to time the approaches so that you do the immunomodulation and turn off the relapses, then you wait a period of time, and then you apply the molecules that are going to be enhancing repair. But there's a timing issue there that we need to work on.
I'd like to take the chair's prerogative and ask Dr. Coatzee a question, or ask him if he might bring us up to date on a program called the Promise 2010 campaign, which was a campaign that funded a number of major projects, but in particular, it funded a number of consortia around the world to look into repair of the nervous system, and maybe give us a little brief glimpse into what's been happening in that area, because it's pretty exciting work.
Well, thank you, Dr. Miller. As Dr. Miller alluded to, the Society made about a $15 million investment through a program called Promise 2010, which assembled 4 international collaborative teams of scientists, 100 people working together, brought them together, in fact, last January in this very hotel to focus on how we can understand what it takes to repair the nervous system, what we can do to conduct clinical trials of nerve repair strategies, because the challenges Dr. Lublin alluded to are very real, that we need to think about when to use a nerve repair strategy in the context of existing therapies, and then ultimately, how do we think about doing an actual clinical trial? As a result of this effort, one of the ways scientists measure progress is how many papers were published as a result of this collaborative effort, and 181 publications came out of this effort. And that may, in and of itself, that's not a particularly exciting thing. 180 papers is a lot. It shows good progress. But from that, very recently, one of those papers focused on the concept of whether or not you could use an existing on-the-shelf existing available drug therapy to mobilize stem cells that naturally exist in a person's brain to go to an area of damage and to stimulate repair of damaged lesions. That group has already started thinking about clinical trials. They're based in the United Kingdom, and they're already designing a clinical trial to use an existing therapy to target these stem cells. Now they have a few ways to go before they can actually start recruiting patients. We have to think about what would be what would they ask in terms of what is being repaired. We'd have to come up with a way of measuring whether or not repair was happening, and then you'd have to take the step of what would the FDA and the European regulators accept as a success in that type of a clinical trial. But I'd like to challenge you to just think about that. We're actually in 2011 talking about a nerve repair clinical trial and a nerve repair strategy. We have a little ways to go, but when we launched the Promise effort just 6 years ago, I'm not certain we thought that we could actually do that. And that's pretty exciting as a result of the efforts that you have helped us do.
So I think we'll take one last question here, and then our staff and some of the speakers, I'm sure, will hang around for a few more minutes.
I'm sorry, I have 2 questions for Dr. Karpatkin.
All right, you get 2.
I'm sorry. What do you think about acupuncture and MS?
What do I think about I'm not an acupuncturist. However,
It's part of physical therapy? No?
I think acupuncture falls into the area of essentially inadequately evaluated therapies in general. It's very difficult to do. It's very difficult to do good studies of acupuncture because it's hard to blind acupuncture, but there have been some attempts, not in MS, but in other areas. I think the general view about acupuncture is that it is useful in certain pain conditions, and there certainly are many people with MS who unfortunately have pain, which is often difficult to treat with pharmacotherapy, with drugs, and acupuncture might be useful for them. The likelihood that acupuncture actually has any influence on the underlying MS process is very small.
And another question, if hot flashes without treatment and light headache due to surgical menopause can cause MS relapse?
I couldn't hear the beginning of that comment.
I'm sorry. If hot flashes,
Hot
and
flashes.
without treatment and light headaches due to surgical menopause can cause MS relapse.
I don't think that hot flashes or menopause cause MS relapses. I'm not sure that I fully understand the mechanisms of hot flashes. That's not a male menopausal symptom very often. But this feeling of having body temperature increased may transiently cause a person with MS to feel worse, but it's not causing a relapse. So on that note, I'll again thank everybody for coming
Dr.
and
Miller,
sticking
can I
out to
just,
the end. Safe travels.